On-the-scene coverage of AHA 13 is supported by Janssen Pharmaceuticals Incorporated.
Welcome. We're here at AHA 2013 here in Dallas. I'm Chris Cannon of CardioSource and here with Tony DeMaria from UC San Diego. And we're going to highlight some of the late-breaking clinical trials presented today. I think we have two that didn't work. And I think some surprises in one of them, I think, quite frankly. Should we start with the nitrites in MI study? This was a look at trying to reduce infarct size, certainly something we try and do with rapid reperfusion, but here trying to go at it pharmacologically.
Yeah, there's data in animals, as there often is. With so many of these compounds, everything works in animals. If we only treated animals, we'd be very effective. But there was some very promising data in animals that nitrites, not nitrates, nitrites, given prior to reperfusion of an occluded coronary could reduce reperfusion injury, the so-called no reflow phenomena. And so this was a phase 2 trial conducted in patients, relatively small, about 160 patients, but they powered it for a 4% reduction in infarct size and area at risk by MRI, and provided some evidence that was an adequate power. The nitrites had to be given about 10 minutes before PCI of acute STEMI, first-time STEMI patients, so a good group. And with an MRI, infarct size, risk areas, the endpoint, clinical endpoints as well. And the bottom line was, as is so often the case, there really was no significant difference.
It is surprising. This has been done, I think, the most promising adenosine, but there are probably 20 different compounds that reperfusion injury, while mechanistically makes so much sense, and superoxides running around contributing to infarction, but it's been really almost impossible to impact.
It's amazing, Chris, from a reduction of vasospasm and reduction of inflammation and reduction of edema and steroid therapy and non-steroidal anti-inflammatories. So many interventions that look promising in animals just haven't panned out in human beings. This reperfusion injury problem really is a significant issue.
Yeah. Well, another big trial now, a 4,000 patient randomized trial from China, looked at acute blood pressure management in stroke patients. So a very well done study that is a very clinically relevant issue of patients coming in. Many are hypertensive, and the question is, should you try and treat to target to get a blood pressure less than 140/90, which would be our outpatient goals as of 2 days ago, and a very reasonable design. But again, here I think a surprising finding to me.
Yeah, it's somewhat surprising too, but a couple of things about this study. This was a very large 26 hospital randomized controlled trial conducted in China, and to all intents and purposes with a really excellent protocol and conducted very effectively. And there's always been the question, at least in my mind, Chris, if you have somebody with stroke and you bring down their blood pressure, could you in fact cause even more damage by reducing perfusion, or do you benefit the patient? And so this was a study that was carried out in thousands of patients, certainly well-powered. One group of patients who were not given any additional antihypertensive therapies over any that they received, and another group who were treated with a specific blood pressure goal of, as you said, 140/90. And what they found, interestingly enough, was that there really was no significant difference, no benefit, but I guess you could say no harm either.
Yeah. You know, what makes perfect sense of controlling blood pressure, I think, does have that hypoperfusion factor. And so the exclusion criteria was above 220. And so we're left with somewhere between 200 and 140 is a reasonable target. So certainly keeping, not being too aggressive in management. And I suppose, you know, thinking of other areas in the diabetes realm, when getting hyper aggressive on lowering glycemic or improving glycemic control or lowering glycemia, that inducing hypoglycemia can have bad consequences. So this type thing of potentially over-treating has certainly been seen in other areas.
Yeah, absolutely. It seems like the trend, as you point out, whether it's blood glucose or blood pressure in diabetics, or now here blood pressure in stroke. Now, these patients had systolic pressures mean of 165, so they were significantly elevated. What was interesting to me was that even in the control group, there was a definite fall in systolic blood pressure over a period of days, suggesting that some hypertension is part and parcel of the stroke process, and if you do nothing, the blood pressure is going to fall down. So I suppose you could say an interesting question is, what would be the benefit in those patients in whom a blood pressure doesn't fall? But at least here, looking at survival and looking at neurologic function, didn't produce much that was beneficial.
Well, this is the latest of the late-breaking trials from the initial session here. We'll have all of the late-breaking trials both in video and in print summaries, and so stay here on Cardiosaurus and On the Scene for coverage of the AHA. I'm Chris Cannon with Tony DeMaria.